For Psychopharm Archive, I am a consultation liaison psychiatrist and academic physician. Subscribe for our next investigation into the molecules that shaped the modern world. Case File 002, the patient. She was 53 years old, and she had been stable on lithium for 14 years. She was a high school orchestra director in a mid-sized city in the Ohio River Valley. She had been diagnosed with bipolar I disorder at 31, after a manic episode that ended her first marriage and nearly ended her career. The mania had presented the way it sometimes does in professionals who have spent years compensating. She had not slept for 6 days, had reorganized the entire school's music library at 3 a.m, and had driven to a neighboring state to purchase 4 cellos the program did not need and could not afford. After discharge, she was started on lithium carbonate. The response was decisive. The grandiosity receded. The compressed sleep normalized. The intervals between mood episodes widened, and then, for long stretches, disappeared entirely. She returned to the podium. She married again. Her lithium level was drawn every 3 months, and for 14 years it had remained between 0.7 and 0.9 milliequivalents per liter. Her creatinine had been checked annually and had always been normal. She had been told at the beginning to hold her lithium if she could not keep fluids down. She had been told this once, 14 years ago. In the second week of August, during a heat wave that pushed afternoon temperatures above 100 degrees for 5 consecutive days, she developed gastroenteritis. She vomited intermittently for 2 days. She continued taking her lithium at her usual dose. On the 3rd day of her illness, her husband found her sitting on the edge of the bed, unable to name the month. The presentation. In the emergency department, she was awake but disoriented. She knew her name. She did not know the year. She could not perform serial sevens. Her speech was slurred. Her lithium level returned at 3.1 milliequivalents per liter. Her creatinine, which had been 0.94 months earlier, was now 2.4. Her sodium was 149. The clinical picture was acute on chronic lithium toxicity superimposed on pre-renal acute kidney injury, precipitated by volume depletion from 2 days of vomiting and extreme heat, with impaired renal clearance concentrating the drug she had continued to take at her usual dose. Lithium was held immediately. Aggressive intravenous hydration was initiated. She received 2 sessions of hemodialysis over 36 hours. Her lithium level fell to 0.8 after the first session and to undetectable after the second. By hospital day 3, her creatinine had fallen to 1.6. Her electrolytes had normalized. The internists were satisfied. The neurologists were not. The persistence. On hospital day 4, with her lithium level undetectable for over 24 hours, the neurology consult team performed a detailed examination. Her speech remained dysarthric, not the thick dysarthria of a stroke, but scanning, syllables broken apart and reassembled with irregular emphasis. Her finger-to-nose testing was impaired bilaterally, with a terminal intention tremor. Her heel-to-shin was ataxic. When asked to walk, she required the support of 2 staff members and listed to both sides without a lateralizing pattern. A brain MRI showed no acute infarction. What it showed was cerebellar atrophy, most prominent in the superior vermis. The expectation was that these findings would improve as lithium cleared her tissue compartments. Serum levels normalize quickly with dialysis. Tissue clearance in the central nervous system takes longer. The brain-to-serum lithium ratio is not unity. A patient whose serum level has been corrected may still be carrying a significant central nervous system burden for weeks. At 2 weeks, she could walk short distances with a rolling walker but could not manage stairs. She had developed a coarse resting tremor in both hands. She was medically stable and no longer required acute-level care. She could not safely return to a home with 14 steps from the garage to the main floor. Case management arranged a transfer to a subacute rehabilitation facility. She was discharged on hospital day 17. At the SAR, she received physical therapy twice daily, occupational therapy once daily, and speech-language pathology 3 times per week. She was discharged after 26 days, ambulatory with a rolling walker for longer distances and a single-point cane within the home. She could dress herself if the clothing had no small buttons. She could feed herself with adaptive utensils. Her speech was intelligible in quiet environments at a slow rate. She had walked into the emergency department under her own power 6 weeks earlier. The name. The diagnosis, though rare, was clear. This patient suffered from the syndrome of irreversible lithium-effectuated neurotoxicity, or SILENT. The acronym SILENT was coined by Adityanji in 1987 to describe neurological deficits that persisted after lithium intoxication, long after the drug had been cleared and the metabolic picture had normalized. The definition requires the persistence of neurological sequelae for at least 2 months after the cessation of lithium, in the absence of a prior neurological condition that could account for them. That 2-month threshold is a diagnostic convention, not a biological boundary. In the published case literature, neurological trajectories unfold over months to years. Some patients show gradual partial improvement, particularly in gait and speech, as the brain recruits compensatory circuits around damaged cerebellar architecture. Others remain static. What the literature does not contain is a case of full recovery. The deficits may soften, they do not resolve. In the 2024 scoping review by Konechny, Dutroux, and Buchert, 117 cases of SILENT were extracted from 91 published articles. Persistent cerebellar dysfunction was the most common sequela, reported in 77% of cases. Other presentations included cognitive impairment, Parkinsonism, chorioathetoid movements, and peripheral neuropathy. Concurrent antipsychotic use was documented in 59% of cases. Fever was reported in nearly 38%. The most common acute presentation preceding SILENT was altered consciousness, reported in over 61% of cases, a detail that matters clinically because the delirium and obtundation of severe lithium toxicity often dominate the team's attention, while the cerebellar injury that will define the patient's future is completing its work beneath the surface. The mechanism. To understand why lithium destroys the cerebellum, we have to begin with a paradox. At therapeutic concentrations, lithium is not merely non-toxic to neurons. It is neuroprotective against precisely the kind of injury that appears to kill them in SILENT. In 1998, Nonica and colleagues demonstrated that chronic lithium exposure at therapeutically relevant concentrations provided near-complete protection against glutamate-induced excitotoxicity in cultured cerebellar granule cells. The protection required 6 to 7 days of pre-treatment, operated through inhibition of NMDA receptor-mediated calcium influx, specifically via SRC kinase inactivation and reduced NR2B subunit phosphorylation, and had an EC50 of approximately 1.3 millimolar, the same molecule that, at therapeutic concentrations, protects cerebellar neurons from calcium-mediated death can, at toxic concentrations, produce the exact injury it was shown to prevent. No published model has fully resolved this paradox. What has been established is where the injury concentrates and what it looks like at the cellular level. Cerebellar Purkinje cells are the sole output neurons of the cerebellar cortex. Everything the cerebellum does, gait, fine motor coordination, speech prosody, is routed through them. They are among the largest, most metabolically demanding neurons in the human brain, with enormous dendritic arbors, high firing rates, and a dependence on calcium signaling that is more elaborate and more tightly regulated in this cell type than in any other neuron in the central nervous system. The neuropathological evidence for their selective vulnerability to lithium is limited to a small number of post-mortem cases, but it is consistent. Schneider and Mira, in 1994, described the characteristic findings in a patient who died with persistent deficits following lithium intoxication: neuronal loss and gliosis in the cerebellar cortex and dentate nuclei, spongiotic change in the cerebellar white matter, and a striking selective depletion of Purkinje cells with relative preservation of the adjacent basket cells. An earlier German neuropathological report documented extensive damage to both Purkinje and granule cells, with gliosis extending into the inferior olives and the red nucleus, and cytoplasmic vacuoles in neurons of the supraoptic nucleus. Animal models confirm the distribution. Rats exposed to toxic lithium concentrations develop extensive vacuolation of cerebellar white matter acutely and Purkinje cell death chronically. The question the field has not definitively answered is why Purkinje cells and not other neurons. The leading hypothesis, proposed by Grignon and Bruguerol in their 1996 review, is calcium-mediated excitotoxicity. Lithium interferes with the mechanisms that regulate intracellular calcium in neurons, and Purkinje cells are disproportionately sensitive to calcium dysregulation because of the central role calcium plays in their normal function. Under toxic conditions, elevated lithium concentrations, fever, concurrent neuroleptic exposure, systemic inflammation, the calcium dysregulation crosses a threshold. Intracellular calcium rises to levels that activate apoptotic cascades. The Purkinje cells die. There are strong molecular reasons to suspect that the specific vulnerability lies in a receptor called the type 1 inositol 1 4, 5-trisphosphate receptor, or IP3R1. The cerebellum contains the highest IP3R1 concentration in the brain, and Purkinje cells express it at levels that dwarf any other neuronal population. Ross and colleagues localized IP3R1 to the endoplasmic reticulum of Purkinje cell dendritic spines in 1989. Matsumoto and colleagues demonstrated in 1996 that mice lacking IP3R1 develop severe ataxia and seizures, establishing that the receptor is essential to Purkinje cell function. In normal cerebellar physiology, IP3R1 functions as a coincidence detector at the parallel fiber Purkinje cell synapse. It opens only when both IP3 and calcium are simultaneously present, releasing additional calcium from the endoplasmic reticulum to drive long-term depression, the cellular mechanism of motor learning. The system requires precisely calibrated calcium transients. Too little calcium in the synapse does not depress. Too much and the cell activates death pathways. No published study has directly demonstrated that IP3R1 density is the specific molecular variable that explains why Purkinje cells are preferentially destroyed in silent while other neurons are spared. But the convergence of evidence is difficult to ignore. These are the neurons with the highest density of a calcium release channel that depends on the very signaling pathway lithium disrupts, in a brain region where the neuropathological injury is concentrated. If a formal link is eventually established, this is almost certainly where it will be found. What has been established experimentally is that lithium's effects on calcium signaling are concentration dependent and, at supertherapeutic levels, can reverse direction. Dixon and colleagues showed in 1994 that lithium at supertherapeutic concentrations paradoxically stimulates glutamate release and increases IP3 accumulation via NMD, a receptor activation in primate and mouse cortical slices, an effect opposite to the protective NMDA dampening that Nonaka observed at therapeutic concentrations. At the same time, the protective mechanisms that lithium engages at therapeutic levels, GSK3 beta inhibition, leading to upregulation of the anti-apoptotic protein, BCL2, AKT1, activation suppressing pro-apoptotic P53, and BAX, follow dose-response curves that were characterized at therapeutic concentrations and have not been shown to scale proportionally into the toxic range. The downstream cascade, once calcium dysregulation crosses the excitotoxic threshold, is well established in general neurotoxicology even if it has not been mapped step by step in lithium-poisoned Purkinje cells specifically. Mitochondria buffer excess calcium until the permeability transition pore opens. Cytochrome C is released. Caspase 3 is activated. Neuronal nitric oxide synthase generates peroxynitrite. The cell commits to apoptosis. Grignon and Bruguerol proposed that lithium, cytokines, and neuroleptics synergize to disrupt this calcium homeostasis specifically in Purkinje cells. The clinical data support the synergy. Concurrent antipsychotic use was present in 59% of published silent cases. Antipsychotics independently affect neuronal calcium signaling and may lower the threshold at which Purkinje cell calcium handling is overwhelmed. Fever, reported in nearly 38% of cases, increases metabolic demand disproportionately in neurons with high baseline firing rates and has an independent association with Purkinje cell death even without lithium exposure, documented in heat stroke and neuroleptic malignant syndrome. The 2024 systematic review by Verdu and colleagues specifically concluded that hyperthermia is likely a significant contributor to irreversible sequelae, not merely a marker of illness severity. Two final points about the mechanism matter clinically. First, duration of toxic exposure is the variable that appears to determine whether the injury is reversible or permanent. The Purkinje cell does not die instantly when calcium homeostasis is disrupted. It dies over hours to days, progressing through stages that are initially reversible and then irreversible once caspase activation has passed the point of no return. This is why the interval between onset of toxicity and correction of lithium levels is the single most important prognostic variable in the published literature. Second, the serum lithium level can be misleading. Central nervous system lithium concentrations do not reliably track serum levels. Lithium crosses the blood-brain barrier more slowly than it equilibrates with peripheral tissues, and it clears from the CNS more slowly as well. Severe neurotoxicity has been documented at therapeutic serum levels, presumably because intracellular and CNS concentrations had risen through mechanisms the serum level did not reflect. Multiple authors have noted that the blood draw is, in effect, measuring the wrong compartment. The impasse. For this patient, Lithium had been the pharmacological foundation of 14 years of stability. It had not merely reduced her symptoms, it had made possible the version of her life she recognized as her own. Lithium is not easily replaced. It remains the only mood stabilizer with robust evidence for reducing suicide risk in bipolar disorder. For patients who respond well to it, the alternatives are not equivalents. Valproate has a different efficacy profile. Lamotrigine offers limited protection against mania. Most second-generation antipsychotics carry metabolic risk. Carbamazepine is used but infrequently as monotherapy. Unlike the clozapine myocarditis literature, where a cautious rechallenge after a reversible inflammatory injury has been attempted with documented success, there is no rechallenge paradigm for silent. The injury is structural. The Purkinje cells that were lost are not replaced. The cerebellum does not regenerate its cortical output neurons. Lithium was discontinued permanently. Valproate was initiated. The patient asked her psychiatrist whether the Valproate would work as well as the lithium had. Her psychiatrist did not lie to her. The aftermath. At 6 months, outpatient physical therapy goals had shifted from recovery to compensation. She had graduated from the rolling walker to a single-point cane. The dysarthria had softened, intelligible in quiet rooms, but the scanning quality persisted under fatigue. Her speech pathologist discharged her at month 7, documenting a functional plateau. The tremor did not respond to primidone. She applied for long-term disability. She did not return to the podium. At 14 months, a hypomanic episode required a valproate dosage adjustment and the addition of Seroquel. At 20 months, a depressive episode responded to the addition of lamotrigine. By the end of the second year, her medication regimen had grown from 1 drug to 3. This is the pharmacological reality for many patients who lose lithium. The single agent that managed the full spectrum of the illness is replaced by a combination that manages pieces of it, none with lithium's evidence base for long-term stabilization and suicide risk reduction. The 3rd and 4th years were psychiatrically quieter. 1 hypomanic recurrence in year 3. No hospitalizations. A repeat MRI at year 3 showed stable cerebellar atrophy without interval change. The injury was not progressing, but the tissue was not being replaced. At 5 years, she was 58. Her neurological examination was functionally unchanged from year 1. The cane was permanent. The tremor was permanent. She had begun teaching private violin lessons from home because she could no longer demonstrate technique, but she could still hear it. She described the difference between her old regimen and her current one with a precision that reflected her training. On lithium, the illness had disappeared. On the current regimen, it was present but manageable. These are not the same thing. What she told her psychiatrist at her 5-year follow-up was that the hardest part was not the cane or the tremor. It was the sound of her own voice. The cerebellum does not only coordinate limb movement, it coordinates the musculature of speech. When the Purkinje cells that govern those circuits are lost, what remains is a voice the patient recognizes as altered, and that alteration does not fade. It becomes the voice. Closing. This case illustrates the paradox at the center of lithium pharmacology. The most effective molecule in psychopharmacology for the condition it was designed to treat is also the molecule whose therapeutic window is narrower than almost any other drug in psychiatric use. The distance between the dose that stabilizes a life and the dose that destroys a cerebellum is measured in fractions of a milliequivalent. Silent is rare, fewer than 120 cases across 6 decades, but the rarity is not a measure of its significance. It is a measure of how effectively the safeguards prevent most lithium exposures from reaching the threshold at which irreversible injury occurs. When those safeguards fail, the consequences are permanent in the way the patient experiences the word, a life reorganized around capacities that will not return. The clinician's task is not to avoid lithium. It is to respect what the molecule can do in both directions. Every lithium prescription is a contract between the prescriber and the patient's kidneys, and the terms of that contract require lifelong vigilance. This has been a clinical and molecular analysis of the syndrome of irreversible lithium-effectuated neurotoxicity, also known as silent. For Psychopharm Archive, I am a consultation liaison psychiatrist and academic physician. Subscribe for our next investigation into the molecules that shape the modern world.